Well, here we are with podcast number 9 of the new season, and the title of today's podcast or show is Why Am I Sleeping All the Time?
Okay, so the word of the day is Bedrich.
Bedrich.
Yeah.
Chuck, you've
Help you
stumped
out.
me. You've stumped me. What is that referring to?
Well, I'm actually going to tell the audience the truth that you actually stumped me because you found this word and I didn't know anything about it. But Bedrich is the first name of a Czechoslovakian neurologist, Dr. Bedrich Roth. And in the 1950s, he decided to devote his entire career in neurology to excessive daytime sleepiness, disorders of sleepiness.
Wow.
Right. So this is interesting because now, currently, we are working on ways to educate physicians about excessive sleepiness. So that's the 1950s. That's 70 years ago, where this guy devoted his career and is now actually considered to be the grandfather of sleep medicine, or the father of sleep medicine, because he was one of the first clinicians to devote his career to this discipline of sleep medicine that only recently has been recognized in Canadian colleges of medicine as a discipline. So we're going to talk about people who present to either a psychiatrist or a sleep physician or family doctor with sleeping too much, and so much that they can't function during the day. It's actually a thing.
I'm gonna interrupt you for just
right
a
ahead.
sec, okay? I love how you're appreciating history. That's usually are focusing more on the here and now.
Yeah.
But I think when you focus on the here and now, you're taking the history into account.
Always.
And it just reminds me of Hippocrates, he's not the father of modern medicine, but guided us into the way that we should practice. And it's so novel that this Bedrich guy is fitting our hypersomnia, or why I'm sleeping all the time.
Okay. Yeah. And so what I want to know from the psychiatrist perspective is, where do you see excessive sleepiness in your practice of psychiatry? So where does it come up?
Yeah, it's a great question, because a big part of depression is distinguishing depression that arises and is significant, or people that have recurrent episodes of depression, or what's called bipolar disorder. And in people that are depressed, they have no energy, their sleep is not deep enough, you've talked about that, but it's not that they're actually racking up more sleep, like 10 hours, 11 hours, 12 hours. That exists in bipolar depression.
Okay.
And the bipolar depression is different in that frequently, and I mean, the even mild cases of depression are terrible, but the bipolar depression, probably it's worse than anything
Really?
you can imagine. Yep.
In what way?
Well, they're racking up 10, 11, 12, 13 hours.
In the depressed phase.
In the depressed phase.
Because, of course, in the manic phase, they're not sleeping.
Exactly.
Yeah. So they
the
go...
exact opposite. Right. And I had a patient of mine that I knew that hypersomnia, sleeping all the time, was a real problem, but I had one patient that I discharged from the hospital that had a manic episode, and I said, please come back if you start to feel down. I wouldn't mind seeing you in a couple of weeks or 4 weeks.
Right.
I saw her again 9 months later.
Okay.
She hadn't given birth. She was, it was 9 months, and I said to her, I said, I don't want to give you a hard time, but you know, when I last saw you, I said, you know, you got to come back and see me soon.
Yeah.
And she says, well, I would have if I could have. And I said, well, what do you mean? And she said, well, I've been sleeping
Ever
nonstop. And when people with bipolar depression, what they describe is they are in bed, they're asleep, they wake up. The most they can do is go get something to eat
And
or
go right
drink
back
or
to
go,
bed, eh?
and they go right back, put their face in the pillow and fall asleep. And that's when it became abundantly obvious there is a difference between bipolar depression and regular types of depression.
And how do you manage the sleepiness in that situation?
Well, we apply different treatments for the for bipolar symptoms to specifically address the depression. But I would rather get into going back to Bedrich.
Or you're gonna put it back on me now.
I'm going to put it back on you so that you can.
I
let
thought I
us
could
know.
rest in this episode, and I wouldn't have
Rest.
to work.
Well,
I was gonna have a nap.
You were going to have a nap.
Okay.
Well,
all right. You're not gonna let me.
you're not sleeping well enough to have a nap,
Okay.
anyways.
All right. Okay, so you want to know about how we look at sleepiness.
Yes.
Yeah, so I think this is really interesting because sleepiness, first of all, isn't recognized in general medicine as a problem. It's not like diabetes or chest pain and heart disease or cough and asthma. It's like, I'm sleepy, and most doctors would go, well, I'm sleepy too, so don't worry about it. Get more rest. But the fact is, there are people who present with pathological daytime sleepiness. And what that means, Chris has told me that I use words that are too big and that I shouldn't be using them. So I'm going to try and be a little bit more careful.
Okay, well, I mean, the least you could do is define pathological.
And I'm going to do that.
Please.
Okay. So when we say pathological, we mean this ain't good for you. You know, it's clinically significant, and it really is not within the range of normal and could be a medical condition. And so pathological daytime sleepiness, one, it's not good for the individual. Two, it's likely associated with a medical condition that requires investigation and treatment. Most importantly, in those people who engage in safety-sensitive activities, like for instance driving a car, really bad, because we do, as certainly in Western society, we accept sleepiness at the wheel as a common thing, and we don't worry about it. As a sleep doctor, we worry about it big time.
I just want to interrupt because you have some experience with this.
Okay, we don't want to talk about personal situations.
Well, I mean, I want to go back. No,
Yes,
let's go
I do.
back. The
Yeah.
people need to hear. We've got problems too, Chuck. You know that. I've tried to point that out. You're
So you
the
wanna
guy
talk
who
about
drove into a lake.
Yeah,
'cause
I
you
did,
were
'cause I was
working
asleep.
Too hard.
Yeah.
But that brought you to the sleep
recognition,
clinic
yes.
and medicine. And I'll tell you, yeah, it's allowed me to be able to have a job. I work at a
in your
sleep
golden years.
in my golden years. Well, you've got golden years too. But anyways,
So I know where we're headed here.
Let's get back to where you're.
No. This is important.
Yeah.
So there is a spectrum of presentation of daytime sleepiness. So number one is it's irresistible sleepiness. It's not tiredness or fatigue. It is literally falling asleep when you should be awake. And there are certain times of the day that we would be more sleepy than others that are natural. They're part of your circadian rhythm. And people think of this as the post-lunch dip. And sometimes they attribute that to just eating at lunch, but that's not the case. The case is that this is a circadian low in your brain clock, and you should be tired somewhere.
Circadian. Give me another.
So circadian is difficult, but it is the timing of your sleep and wake cycle through the day. So human beings are diurnal, which means they have a day and a night. So we sleep at night and we're awake during the day.
Okay.
And really our physiology is supposed to do that. Okay? So we're not really supposed to be awake in the night. Okay? So we are diurnal, and that is a circadian phenomenon. It's driven by the brain clock.
Okay.
Okay? And the brain clock is set by exposure to light in the morning, right? So we can have people who are excessively sleepy because they don't get enough sleep at night, which is why I had a car accident.
Right.
So you will have a high sleep drive during the day when you should be awake if you haven't gotten enough sleep at night.
Right.
And that's on a day-to-day basis. That's not like 6 days in a row and then all of a sudden you're going to fall asleep. If you miss 1, 2, 3, 4 hours on a Tuesday night, Wednesday you're going to be sleepy. Okay. So that's one form that is not pathological daytime sleepiness, because the disorder is you didn't get enough sleep. It's not a medical one. It's a behavioral problem. You're not getting enough sleep. If you get enough sleep, you're not sleepy during the day. This is different than what Bedrich Roth was exploring, because as a neurologist, the quintessential, there I did it again, the key disorder in daytime sleepiness in neurology is narcolepsy.
So the key disorder, that's quintessential.
I was trying not to say it again.
No, I just wanted to clarify.
Yes, yeah.
Okay,
yeah.
Go ahead.
Okay, so that's the classic neurological disorder that is explored by neurologists and sleep doctors, narcolepsy. And that is a lack of control of your ability to stay awake and a dysregulation of REM sleep, dream sleep.
Okay.
Okay, so people with narcolepsy, one, won't be able to stay awake.
Okay.
They'll struggle desperately to stay awake. And the other is they will experience weird symptoms. One of them is cataplexy,
Okay.
where with an emotional trigger, happy,
Okay.
sad, angry, they will actually lose control of their body. They will become basically like a stroke. So they'll be aware, but they can't move their arms or their legs, or they'll have weakness in their face, on both sides of the face. That is cataplexy.
I'm gonna look up cataplexy later on, not now.
Okay. You don't
See?
trust me?
No, I want to look at the Latin term, because I think what's it got to do with cats and plexi?
Good point.
But there's a good reason.
Yeah. One of our producers might be able to tell you, because she has 2 cats.
She has 2 cats.
Yeah.
Okay.
So
All right. Yeah. Well, we'll catch up later. At the next episode, we'll explain what cataplexy is.
is.
Well, you already have explained it.
Yes.
It's just.
We don't know where the word comes from.
Yeah, that's all.
And so then there's sleep paralysis, where you would wake up from sleep in a dream state and be paralyzed. That's a very terrifying experience. There are hypnagogic hallucinations, which is called the old hag syndrome.
Really?
People will wake up in dream sleep, they'll be awake, and they will see an old witch sitting on their chests. Yeah, so it's pretty cool. Or they'll have really...
Well, I'm glad to hear that, because I've never had it before,
No.
and your description, I guess, makes it easy for me to know that I didn't have it.
Right, and it's very terrifying.
I know it's terrifying.
Yeah.
I've seen people that
Yeah.
have sleep paralysis, and
Yeah.
it is terrifying.
And so these are symptoms of what we call REM intrusion, where REM, the brain state, intrudes into a waking state, because it's not supposed to.
Right.
We're not supposed to be awake when we're in REM sleep.
Right.
And so people will have these experiences, or they will go straight into dreams when they fall asleep, which is, again, not normal.
Right.
Okay? So this is narcolepsy, very specific disorder, very low prevalence, less than 1%.
Right.
Okay? But devastating to a human
Right.
being who has it. And I have physicians who have it. I have heavy equipment operators who have it. I have nurses, hospital staff, people who do shift work. So it's out there. So the spectrum then goes from narcolepsy to what we call idiopathic hypersomnia. So these are people who are sleepy, excessively sleepy, difficulty staying awake, but they have no symptoms of narcolepsy, and the pattern of their sleepiness is continuous. So they just sleep and sleep and sleep, and when they are awake, then they have very long naps because they can't stay awake. So the wake mechanism in the brain is broken, okay? And that's a very complicated thing that we now have many different pharmacological agents we use to keep people awake. In narcolepsy, their sleepiness is limited. So if they have a short 10 to 15 minute nap, they're fine.
Interesting.
But that happens continuously through the day.
Right.
So if you sleep deprive someone with narcolepsy, they have way worse symptoms. So if they get the sleep that they need, they can manage okay, but they do need medication to get rid of the cataplexy and get rid of the daytime sleepiness completely. So these are the spectrums of disorders of daytime sleepiness. And there are others that I actually won't discuss here today because this is a lot to talk about. But the thing that distinguishes narcolepsy from idiopathic hypersomnia is the pattern of excessive sleepiness and the ability of a narcoleptic to resolve the sleepiness through short naps. Wow. Whereas the other, they just sleep. And you can have idiopathic hypersomnia with a long total sleep time, which is in excess of 9 hours, or short total sleep time, which is less than 9 hours.
So it sounds to me like you're able to, as a sleep expert, make a diagnosis from what was learned from Bedrich Roth, but now that will get augmented. Like a doctor thinks someone's got anemia, they send them for a simple blood test that tells them it's anemia for sure. You're saying if you really wondered, you would confirm that by doing a sleep study.
There's no question. We use the sleep study as the baseline of testing, and then in certain countries, not in Canada, they'll actually do lumbar punctures, which is taking fluid out of the spine and analyzing it for the genetic predisposition to narcolepsy.
Wow.
Which actually, if we did do that, helps us in treating the patient.
Oh, for sure.
Because it distinguishes the person with true narcolepsy from the person with idiopathic hypersomnia, and we treat them differently.
Wow. Okay.
So the other thing that's really important, and I'm going to go back to you now.
Okay.
There's a very high prevalence of depression in patients with narcolepsy and idiopathic hypersomnia. So there is tremendous crossover here. Your example would be bipolar disorder, mania, depression, and my example would be disorders of hypersomnia, where the patients become depressed as a result of their lack of ability to function in a normal way.
Right, and it wouldn't have to be necessarily that the person would have bipolar disorder. The key symptom of depression is no energy.
Right.
And that is probably, these are the patients that you'll refer to me where the primary problem is they're saying I'm falling asleep all the time, and if they get depressed because they have no energy, then I get to see them.
Right, exactly. And so then the other symptom that you actually raised and that Bedrich Ross actually investigated was the term sleep drunkenness.
Right.
Okay, and that actually is sleep inertia.
Oh,
so
okay.
it's the inability to come to a full state of wakefulness after sleep. So for those people who totally recognize, I woke up on the wrong side of the bed.
Okay.
Or I had a nap and I woke up and I felt worse than when I went to bed for my nap. That is sleep drunkenness or sleep inertia. It's that you still have the inertia for the sleep state and can't get out of it. and come to full wakefulness.
Right.
Okay.
So would that also include people that say, I can't get out of bed in the morning. I mean,
Yes.
I'm just too exhausted.
Yeah, and that's again, we see this in depression.
Right.
They cannot get out of bed. So distinguishing mood from sleep is to say, well, is it because you have no motivation? Are you fully awake but can't get out of bed? Or are you truly sleepy? And they can answer that question.
Wow.
But these are subtle distinctions which you would appreciate that haven't really become, on the radar of general medicine until probably now, where there's going to be a push. One, to determine whether sleepiness to excess is an indication of an underlying medical illness. So people are actually investigating that. Is it actually a presenting symptom of some other disorder? Is it common in cardiovascular disease or any other disease? Or is it something that's independent of disease and is a sleep disorder? Or is it from a psychiatric illness?
Right. Yeah, it's this giant movement that we've talked about from you need to make a diagnosis. If it's bad enough, it's considered considered a disease, which we can apply a diagnosis to. Mm-hmm. But as time goes by, there's going to be a recognition of there are variations. And so instead of making people feel like they have a disease, they have a problem with their physical health.
Right.
Just like in our psychiatry, I refer to patients that have a condition as you've got a mental health problem.
Yeah. So the last thing that I want to sort of mention in distinguishing human states of tiredness is the difference between sleepiness and fatigue, which is often the question that we get from primary care physicians, general internists, because those are the doctors that will have patients who present with fatigue. And what's the role of sleepiness in this? And a fatigued patient, as you've described in depression, is one with low energy.
Right.
And that's a physical state of low energy.
Right.
Sleepiness is a cognitive state and a loss of cognition. Right? So we drift into a sleep state. We're cognitively disengaged.
Right, yes.
And it's an important distinction to make that is not in the general norm of general medicine. It's not something that doctors pay attention to, and they will now as there's more education, because what I've learned over 22 years of doing sleep medicine is that these cognitive states are actually at the core of many patients' complaints.
Yes, well, exactly how, as I mentioned, I think at our last podcast, people who are struggling with anxiety, it's mostly they can't concentrate, and that they know will stand in the way of their performance
during the day. Yeah, and so it is, in my view, it's cognitive functioning, which is concentration and memory. Those are the two big domains that
thinking,
are easy,
really,
and
right?
Thinking,
yeah.
That are easy for patients to go, well, yeah, I've noticed my memory isn't as good as it used to be. And this isn't dementia. This is just someone who's really cognitively tired. And they're coping with their day, but they may crash at the end of the day and fall asleep at home instead of getting on with their day and getting ready for dinner or whatever it is that they have to do. They just don't have the energy, but then they fall asleep. Whereas there are other people who don't have the energy, they're fatigued, but they can stay awake. And those are two completely different things. And the point being that we treat them differently, right? And so if it is, the core of this is a mood disorder or anxiety, we're going to focus on treating that to relieve that sense of fatigue. If the core of it is actual sleepiness, we have a range of medications that we use to keep people awake.
I see, yeah. So Yeah, it's I now know, and I didn't know before, the distinguishing the fatigue from the sleep disturbance, because I thought, well, if they're fatigued, that there's something wrong with their sleep.
Not necessarily.
Exactly, and as you're saying, I should be looking at it like that's different than sleepiness, where somebody cannot stay awake.
Right. Good. Well, I thought that's a good covering of a topic that I think is quite unique, and will be of great interest to people, especially those who resonate, that the concept of sleepiness and fatigue resonates.
So what's going to be our call to action or homework? What's the one thing that...
Mine?
Yeah.
Yeah. So what I want people to do is now reflect on what we were talking about and ask yourself, are you excessively sleepy, which means you can't stay awake when you should stay awake? Or do you just have an increased need for sleep that when you achieve that, you're fully awake? That's something for people to sort of reflect on and look at for themselves.
Well, my call to action or homework is going to be that if you don't have any energy, then you need to see your doctor and talk about, I don't have any energy. That is something that's important, and the doctor will know what to do.
Okay, so we will now get our heads to bed.
Yeah, heads to bed.